We've already heard from Secretary Yi and from Neeraj, so I just want to briefly introduce the two new faces on the stage before we get started on this panel. Sitting to Secretary Yi's left, I guess, your right if you're out in the audience, we have Rekha Ramesh, who's Executive Director for Public Policy at Gilead Sciences and can give us a sort of perspective of how Gilead approached its engagement with the state of Louisiana. And then sitting to Rekha's left, we have Rina Conti, who's an Associate Professor of Markets, Public Policy, and Law at the Questrom School of Business at Boston University. She works on a range of questions related to drug pricing policy, but in particular advised the state of Louisiana on implementation and soon evaluation of its initiative. So, Rekha, we just heard from Secretary Yi, so I want to start with you and get your perspective on how Gilead approached its engagement with the state and what the most important considerations for the company were.
Absolutely. Thank you, everybody. I want to start by, on behalf of Ezequa Therapeutics and Gilead, thanking the state of Louisiana for their extraordinary kind of leadership and commitment here, and to express our excitement to partner in this exciting public health opportunity. As Secretary Yi mentioned, the first patients have received treatment in Louisiana, and my colleagues on the ground, a few of which are here today, have talked about how both providers and health plans have opened restrictions and have treated patients. And that's a very, very exciting thing to be a part of. So I'll start first with the broader considerations in terms of the kind of environment in which Hep C has evolved. And then I'll talk specifically about Louisiana, and I think Dr. Yi has mentioned some of the particulars there, and talk about where we landed. And I think, Neeraj, to your point, on this modified subscription model. Gilead for a while has been very committed to meeting governments and payers where they are, and finding new ways to partner on innovative solutions for patients. We understand with hepatitis C that these are populations, especially in Medicaid and corrections, that face kind of disproportionate prevalence as well as access to care, quality care issues. And so it's very important to find that middle ground on behalf of us and the state. We've also learned from embarking on the Hep C journey that it is a journey, right? And as payers have opened access and started treating patients, that there's a curve to how this happens, right? And in the first few years, there is a budget impact that is associated with curing, after which there's a plateau and there is a decrease in number of patients. So that rise and fall, due to the limitations that governments face on a one-year budget cycle, is very difficult to absorb. And even though prices have come down with competition, as has been referenced, that budget impact, and I use those words very specifically, is still a very important piece of this. At the same time, all this is happening, we have greater access. We're showing, right, and there are a number of abstracts and research studies that elimination is possible when you open access, right? And the more patients you reach and the more patients you treat, you're able to eradicate the disease. So moving to Louisiana, right, the key parameters here are we have a partner in the state that has been extremely committed to the goal of eliminating disease within Medicaid and corrections over a 5-year period. And access was previously limited in the state, so now we're embarking on this journey together. We've talked about the prevalence being high, especially in these populations, and the state was able to kind of be at potentially slightly incrementally increase their spending due to the Medicaid expansion, right, where state is drawing down on an enhanced federal match that results from Medicaid expansion. Let me move now to this kind of novel payment arrangement, right? Part of the consideration here to your question was, how do we provide a predictable expenditure for the state and spread the budget impact over time? And that's kind of where we started with this and how we thought about this in responding to the SFO that you mentioned. while still providing an incentive for the state to want to continue finding patients and curing patients over a 5-year period. So that's why we've partnered with a authorized generic version of Gilead's Applicability. And then it took considerable effort to get here and to implement this model. I think this is the first of its kind. It's being implemented under the current constraints of the system. So there is an expenditure cap, and after that, the state receives free drug on an annual basis. We believe in what Louisiana is doing, and this does pose a bit of risk on behalf of the company. But we've tried to mitigate that, obviously, as we've had conversations. I'll end by saying that for years, we've been working directly with governments around the world, in the US, to find solutions that work. So we're excited about this, and we look forward to continuing to partner as different models arise.
Great. So, I think one of the goals for the rest of the panel is to sort of broaden out and think about how do we use these types of tools in other settings. Before we do that, I want to sort of focus in on what's the key insight here and what's new. So, obviously, and Neeraj, I think you touched on this in your opening remarks, that the general idea of, volume-based pricing or volume-based discounts or what have you is not a new one. So I think one question is, what's distinctive about Louisiana's, what Louisiana is doing here relative to what's come before? I think it would also be interesting, are there commonalities between what Louisiana has done and what other states have done in the past that might not meet the eye, but are important to think about when generalizing these ideas?
So I think the two distinctive things that Louisiana is doing, or in general the modified subscription model or a subscription model tries to do, is one, that there is a commitment to treat a certain number of people. So the discussions between the state and the pharmaceutical firm have been that we are committed to treating a certain number of people, and that makes the pharmaceutical firm more confident that they will expect a certain amount of revenue in the future, and that helps negotiate the price down to something that is affordable. I think the second distinctive thing is that beyond the cap, price is no longer a barrier to access. So in a volume-based discount model, there's always a positive price that you need to pay for a drug when you're treating an incremental patient. And in this model, beyond a certain limit, that price is zero. And that kind of really creates the incentive for the state to invest in testing and treatment and linkage to care, because they know that there will not be an additional expense for the drug beyond that.
I just want to add one thing. And I think one thing that's very unique to our model, too, and I think part of it, as we reflect, is why Secretary LeBlanc, who's the Secretary of Corrections, and I work very closely together. And I do think this is the first example of a Secretary of Health working directly with the Secretary of Corrections on a public health issue at this level. And I think he and I have such a great relationship because we've spent so much time in a situation room or command center, because in our first year, the governor's leadership, 85% of our parishes or counties had weather events. Mm-hmm. And so we've worked very closely together all along, and I also think that's an innovative part. And this focus on population as a whole, not just Medicaid solutions, but broader public health solutions that involve corrections, is fairly novel and one that I'm not familiar with in other states.
I have an addition as well, which is, I think the other really important thing here to appreciate is that we do modified subscription type purchasing for other types of medical care goods, but those are largely in the preventive sense. So those are things that are effective and that are intended to prevent people from becoming ill. So for example, we do a sort of modified subscription for certain types of vaccines that are scheduled. What's really the other piece that's novel here is that this is a treatment and it provides a cure. The goal of public policy here is actually to improve public health, not to minimize expenditures in this case. And here we have a state working with the federal government and the private parties to enter into a voluntary agreement, not a required agreement or mandated agreement to solve this, to expand access.
So we've been focused so far on the specific case of hepatitis C in Louisiana. So is this a set of strategies that could be useful in other settings? And what might those other settings be in particular? What characteristics do you think other settings where these tools might be useful would tend to have? Rena, do you want to start?
Yeah, sure. So really just to pick up on that point, which is this is a cure. And secondarily, it affects a population that is underinsured. And so just to put a finer point on this, we are living in an unprecedented time in American medicine. The cures are coming faster than before, and then in prior generations. And we are looking at new treatments that are not only going to convert deadly diseases into chronic illnesses, but are going to cure them not only for people who are elderly, but for young people, for children, for adolescents, and also for the working age population. The financing of cures and things that truly are effective is generally left to the federal government, for which there is no annualized budget. The federal government can expand budgets in order to provide access to things that really do work for the elderly population because of the way it's financed. The state, and even I think many employer-based insurance programs, they don't have the luxury of wanting to expand out budgets in perpetuity and just have premiums rise or have the taxpayer foot the bill. Instead, they really do have to balance budgets, and they really do need to figure out where that money is going to come from, whether it's going to be through taxation or through cutting services in other ways. So if you think about it from that lens, what we're talking about are diseases that are affecting younger people and people who are largely insured either by the state or by employers that may provide actually pretty skimpy coverage. And so there happen to be a lot of treatments or a lot of diseases out there right now that are being targeted by pharmaceutical companies that have those type of characteristics. So for example, hemophilia, sickle cell, certain types of mental illnesses for which really it's the state or it's employer-based insurance that is going to be the payer there, and for which they're going to have to find ways to actually improve people's health and provide access, both to address current illness, but also to forestall other economic implications, which are not being able to work, not being able to take care of your family if you can't actually get access to these treatments that are coming.
But just also the incarcerated population, because incarcerated populations are covered by state general fund dollars and those trade-offs are imminent when those decisions are made, the public generally is not going to be favorable to making trade-offs K through 12 to treat everyone in jail with X or Y. And so I do think, and companies aren't going, there's not a lot of loss, right? These pills cost generally dollars to make, so to treat people in jail. And so I think this applies to many conditions in jail, whether it's cancer or addiction, but also just to remember, as you said so eloquently, that Medicaid covers certain populations, and we have to think about the fact that we cover in Louisiana 60% of the kids, and about that number of are pregnant women. And so any disease or condition that affects, and nationally those numbers hover around 50%. And so any disease or condition that affects those populations has higher constraints in terms of being able to mortgage or come up with more money for. And so these types of models could be very applicable to childhood cancer cures, rheumatoid arthritis, sickle cell, and so on.
Right, and I do think that any condition for which the option of not treating is really distasteful, either because we're really talking about young kids dying, or young kids not being able to work and be productive members of society, it's going to be very difficult to say no in the normal way in which we're doing this. We're going to have to find other ways.
So Matt, if you kind of just think of the economics of this, you can argue that a subscription model, so let's assume that we can do subscription models not just in Medicaid and corrections, but also in private insurance markets, then one can argue that the subscription model is better than kind of linear pricing. And it's well established because of two reasons: that with linear pricing, you kind of have the incentives for innovation, but linear pricing creates what economists call deadweight loss from monopoly pricing, which is the higher prices mean there is an access problem, that people who should be buying the treatment are not able to afford to buy it. So in that sense, this model is applicable to all drugs. But if you say, how do we kind of start to think about where to implement it first? Then I would say we need kind of three conditions. One is we need to pick drugs where this deadweight loss is the highest, or in other words, where the access problem is the highest. And that's why Hep C was such a great example, because we saw the access problem for Hep C. The second thing is we need to pick drugs where reducing the price of the drug will not lead to inappropriate use. So there could be other drugs where you make the copay equal 0, and maybe it leads to overprescribing of, say, antipsychotics, and we don't want, or overprescribing of drugs for ADHD, and we don't want that. So we want to make sure that we limit it to drugs where even if the price is 0, only people who actually clinically need the drug are getting it. And the third thing is this model solves the access problem, but it only solves the affordability problem if there is competition. So if there is no competition, the upfront payment that you will pay for a breakthrough therapy is still going to cost you billions and billions of dollars, right? Because you have a monopoly and there's no other competition. So this problem, the affordability problem, is only solved when there is competition. So I would say that's kind of the third condition, that we want drugs where there is competition. If there is no competition, it will solve the access problem, but not the affordability problem.
So I actually slightly disagree with Niraj here. So I don't think that competition is a binding criteria. I think instead what is the binding criteria is a willingness by the pharmaceutical companies to want to engage and to really care about access here. So one could argue that we're in a special case because it's a competitive space, but I would say instead, really, what is special here is that, again, there's no mandate, there's no requirement. This is a private company that deeply cares about patient access, partnering with a state that has the same objective. So I think that there are many innovator companies that are particularly innovating for these type of conditions, for which restraining access is going to be untenable. Not just because they want to profit maximize, but because, again, delivering on the promise of treatment is truly what they are doing, as much as the state needs to come up with finding ways to access and pay for it.
And I agree with Rena and disagreeing with Niraj, sorry, in that there are two other conditions. I think one, and I see Wendell Primus, the threat of regulation or policy change and or public outcry are two other tools. It's not just competition. So let's say we had a childhood cancer cure. I'm the mother of 5. Let's say it cost a bagillion dollars. The public would not stand for that. There would be regulation. So I think that's the other tool. The competition is an independent tool, but I do think there are legislators who can enforce.
No, I agree. But the thing is, and you can see this with the Hep C example, when there was only one drug on the market, the price was very different than when there were multiple similar drugs on the market. Did suddenly pharmaceutical firms become more altruistic and said, oh, we really care about people? No, it was the competition that drove down the prices. So I think that's a first order principle in economics, that the more competition you have, the cheaper it is or more affordable a drug is going to be.
I would argue competition helps the company be generous, or be motivated. But it's not the only thing.
Yeah.
Public pressure, private pressure from the parents of kids who are suffering, and from the kids and from the young adults who are suffering, also creates pressure that in a voluntary system as ours, both parties have to respond.
Okay, so I think to summarize this discussion, definitely can solve the access problem without competition, disagreement on whether competition is necessary for this to be a useful model to get savings for the state. So moving on, suppose we all agree we've got a drug and a state where this type of model makes sense. What are states interested in implementing that type of model? What can they learn from Louisiana's experience? What were the sort of most important challenges Louisiana had to overcome that if you were talking to a policymaker in that state, Secretary Gee, you would communicate to them?
I think partly it was important to have a laser focus on this issue and to keep at it, right? So if you want to change something, it's not easy, and to not get discouraged. I think this notion of bipartisan effort, having Senator Cassidy, my governor, John Bell Edwards, the only Deep South Democrat governor, bringing in CMS early, I think was important for us. We did not want to get 90% down the path, and then our federal partners said, hell no, we don't like this idea. So making sure that very early on, now they're not allowed to bless things in a certain way, but they certainly were allowed to guide us and work with us. I think working with the advocacy community, there were multiple times along our journey that there were threats of lawsuits, and really bringing them along to say, we're here, to help solve this problem. Let's work together, because lawsuits are a crude tool for change. What we're looking at is true innovation and reform. And I think also bringing them along to help us with our strategy. And then I think asking, what also humbles me is there was nobody that I asked for help, including Rena and Neeraj and Josh or Alex, who said no. I mean, I think I think don't underestimate the resources that you may not be aware of in your state. It might not be your own state Medicaid budget. It might be a private foundation like the John and Laura Arnold Foundation, but resources will come. If you have the right idea and it's compelling and meaningful, then resources will come.
But Matt, just one other thing, that it took Rebecca 2.5 years after she said, I think this is a good idea, to actually implement it. And I feel like, in some sense, going forward in the future, it should not take other states 2.5 years to implement a good idea. So I don't know what it takes, how can we shorten that time window? But when I talk to states, a lot of them don't want to do anything because they're just daunted by the timeline. They're like, if it's going to take 2 years, I'm not going to be in office. Let's move on, do something that is a quicker win. So I think we need, I don't know what it is, but we need something that makes it easier for other states to now actually do it. That instead of taking 2.5 years, they can implement this in 3 months. And maybe, Rekha and Rebecca and Rena have ideas for how to do that faster.
Well, I would also say I don't necessarily think there is a one-size-fits-all solution, right, on the state side. Mm-hmm. I mean, I think what works for Louisiana may not work for another state. And so I think assessing what states need and what the right model might be is a first step. And engaging in that conversation versus, is this the model for everyone?
So I think one of the things that I've definitely learned is that one could come up with ideal ways of solving this problem that really are fundamentally a challenge to the way in which the current system works. So Medicaid best price, 340B drug discounts, these are realities that actually are the architecture of creating of drug pricing and drug access in the United States. And so thinking about so if we're not going to blow up best price and we're not going to fundamentally alter the 340B program, how do we actually get around, or how do we actually live within those boundaries to create access opportunities? I think those structures are serious, and they're real and needed to be overcome. I would say it was really exciting to see the policymakers, both the state but also the federal government, think very creatively given those structures.
I think one thing, too, is it's very hard as a state policy leader to know what's going on in other states. And so there are all kinds of efforts, whether it's the Millbank Memorial Fund. We now have a secretary's monthly call where we share, but those things are relatively new. And so the sharing state to state has been very difficult, whereas Medicare, there's a national database, there's central policy. Medicaid often is challenged. There are places like Oregon Health Sciences University that help collate best practice and share, but it's generally fairly hard. And so there is a greater need, I think, than what we currently have to spread that type of innovation and have a policy manual for other states. And so I know CMMI tries to do that, but it's kind of a crude tool. I think certainly that's something that could be explored.
And I think as you embark on this journey, right, and study the metrics and figure out what's working, and you're able to really then advise with some data and information in terms of how it's going and what worked and what didn't. I mean, I think that's very important in the implementation science piece of this, right? I mean, we're really at the beginning. So I think those best practices also are a lot that we can all learn from.
Yeah, definitely.
So just to follow up on this discussion a little bit, I mean, it's been alluded the 2.5 years from sort of conception to implementation. If another state were to want to do this, do you think the timeline is that still at 2.5 years, or because of the pathway that Louisiana has forged here, that in fact there's a much clearer path from point A to point B than there once was? Secretary.
Other states are Washington State has followed. Other states are looking. I don't think so. I mean, now we have a waiver. Now there's model draft waiver language. I mean, there's a not a waiver, but there's CMS approved our state plan to enter into this agreement. We did not need a waiver. Sorry for that miss. But yeah, so all of that has been done. We can't, there's a lot of discussion nationally about transparency. Now we are not able to be transparent about the price, so that's a challenge. But on the other hand, I think a lot of the work has been done and can be spread. I think that it should be a lot easier, and if it takes that long, I'd wonder why.
Yeah, and again, the architecture of like the two poles of you need to deal with Medicaid best price, and you need to deal with 340B, and those things stand. What's the pathway forward, given that has now been exercised by this state and will likely be exercised by others?
And I think in the long run, we need to kind of remove those barriers. So everyone understands that Medicaid best price is a barrier to these kind of models. And we need new public policy or new regulations to say that, let's allow a waiver from the Medicaid best price for these kind of new innovative models, and maybe do it not wholesale, only for certain classes of drugs and so on. But I think the time is now to kind of not just work within the constraints we have, but to start to dismantle some of these constraints and see if we can come up with a better way to price drugs. For example, if innovation continues to happen the way it is happening, what would happen if you have a cure for Alzheimer's disease, or what would happen if you have a cure for diabetes? Our current pricing model doesn't work. That if we have a cure for Alzheimer's or diabetes, we'll have the same, in fact, a much worse problem. That instead, I can guarantee right now that with current pricing, that there's no way we will be able to treat 80% of the people who need the drug for Alzheimer's, or 80% of the people who need the drug for diabetes, because their prevalence is way higher than Hep C. So even if you do value-based pricing, you're not going to get there. So we need these new models, and the only way we can kind of implement them on a larger scale is to start breaking down these constraints.
Well, I certainly do think that Medicaid should get the best price. And so, Wenzel may talk about that a little bit, but I'm not sure that that's the first thing I would try to address because we found a way to get around it. I mean, 340B covered entity, supplemental rebate agreement, we were able to do this without a waiver, and that could be done today by 49 other states if they wanted to. So although I think it's complex, obviously, and so we need to make sure that as we, I call it the whack-a-mole. You don't want to whack the mole and then it pops up somewhere else and creates unintended consequences. So, right now I don't want you to get rid of Medicaid best price because it helps me afford drugs. And so I think that would have to go along with a whole set of drug pricing reforms that would be understanding of the continued need to incentivize innovation because, again, in this situation, we're talking about a hepatitis C cure, which is a very high value. And so you don't want to say, okay, that was the other consideration as we went along this journey is we don't want to incentivize future cures by saying, okay, as soon as you come up with a cure, you're going to have your profits, So that's why I think this was such a delicate dance,
And I think,
Sorry.
So what I'm advocating for is not getting rid of Medicaid best price, but if there is an innovative deal, then that deal is accepted from Medicaid best price regulations. Because I agree that there is a role for Medicaid best price regulations for a lot of drugs, but if someone is trying to innovate and make a deal that's going to expand access, that deal should be out of the the constraint should not be that the deal could not happen because it implicates Medicaid best price.
So maybe. I would say that, again, living within the current structures, there's lots of room to do innovation. And there's also lots of room to take the current structures and just expand on them and just kind of rethink them. And so I think there's a lot of interest in alternative payment models. Much of that interest is for drugs that don't really work that well. And so in that setting, we don't necessarily need to reinvent the wheel or blow up Medicaid best price. Instead, we just have to kind of think harder about how we're using our resources for providing access to these treatments. I think the really novel thing here is here's a cure. And the current structures allow for innovation and access for a cure.
And I was probably remiss, but for those in the audience, Rena, can you just give us 2 sentences on what Medicaid best price is, just to maybe bring this conversation back?
Sure. So it's a federal regulation that essentially creates an entitlement to the states that the states will get a supplemental rebate. The states are entitled to the best price for any given drug that they cover. And there's a statutory rebate attached to that, which Congress sets. But then there are supplemental rebates that the states can get that the states can negotiate on top of.
And so it has to be the best price that the manufacturer has given to any other payer for that drug in general.
With some exceptions.
With exceptions.
Yes.
And a key exception came into play here.
Which is 340B.
Yeah. So we've been sort of gone round and round. Debates over drug pricing often come back to the sort of trade-off of high prices can impede access, but they also potentially create an incentive for innovation. So the sort of potential advantage of subscription models is they can sidestep that tension to some degree. They expand access while preserving manufacturer revenue. Is that enough to sort of get to where we should be on prescription drug policy, these sorts of win-win policies? Or do we need to be thinking about policies that would also affect manufacturer revenue in some way?
So I think these kind of policies are a good start, that they help, as you said, sidestep the trade-off to some degree. The other thing is, 3 years ago, I presented at this same stage where we were kind of talking about the pharmaceutical supply chain, which is it's not just manufacturers, but there are PBMs, wholesalers, retailers, pharmacies who are also involved in that business. And what we showed was that out of every $100 in drug spending, about 40 goes to the middlemen or people in the supply chain, and 60 reaches the pharmaceutical firm. So I think there is a lot of room for efficiency within that supply chain, which is also monopolistic. So there are like 3 wholesalers that control 85% of the market, 3 PBMs that control 70% of the market. So I think we need to look not just at pharmaceutical firms to kind of get the savings, but also in other parts of the supply chain. But yeah, there are certain drugs where their price doesn't justify their value, and there you could argue that, you know, we want to look for savings directly from the manufacturer.
And the supply chain is broken for certain populations. And when we look at, I'm an obstetrician, we look at drugs developed to treat pregnant women's conditions, or even our understanding of how, how pharmaceuticals are impacted by a pregnancy, the understanding is minimal and the research is inadequate. Similarly, for something like sickle cell disease, something that's incredibly disabling and painful, you know, the research on that condition doesn't match the important nature or the public health toll that disease takes. And so, or you can talk about contraceptives. I mean, the IUD was developed in the 70s, and arguably there hasn't been significant innovation in the area of contraceptives commensurate with the global need for, you know, issues dealing with population. So I think there are huge market failures. Victoria Hale, who was on the committee with us, has tried to solve those, diseases in developing countries like leishmaniasis, that just there is not a for-profit motive. There was a Zika vaccine, a Secretary of Health for a state that has inundation of water and may have mosquito-borne illnesses like Zika. You know, this was developed by the U.S. government, was given to Sanofi, and then they decided not to produce it. So when we have market failures like that, when something is not going to be profitable, how does the U.S., in the interests of its people, step in and affect the supply chain? I think that's a really important consideration. Secondarily, you know, as an OB, I'm trying to get penicillin for someone for their syphilis. It should not cost $2,000, period, end of story. It should not. So that is something where I think there's a market failure and we need to step in. I think it's a case, I wouldn't say there's a broad-scale solution here because you're looking at innovation, but something like penicillin should not be unaffordable, should not be out of reach. And something like 17-hydroxyprogesterone, something that prevents prematurity, should not be, you know, initially $1,700 now, I don't know, $900 when it really costs $9. And it's not really innovative because it's been around for decades. So I think those are things that I'm concerned of, are things that are population health problems, public health challenges that we're not solving because we rely on a for-profit mechanism as our pipeline. And that mechanism is important and reliable for certain things, common conditions, things like hypertension, diabetes arguably, but for other things like sickle cell disease, contraceptives, pregnancy-related conditions, arguably it's not so much. And so there's not a one-size-fits-all, and we need to have real discussions about these things because there are also, just finally, drug shortages. We look at certain areas where we just run out because there is not a sustained supply or necessarily regulation and or enough visibility on the national supply chain for certain things that are very important. And so that's another market failure that needs to be addressed that has to do with the economics of pharmaceuticals.
Rika, Irina, do you want to jump in on this one? Or?
So I think that what we're seeing is 2 things. The first is that there's a lot of people who make money off of the purchase and sale of drugs that have nothing to do with being innovation or innovative drivers. And for those entities reforming that system, whether it be pharmacies, hospitals, physician offices, PBMs, I think that makes a lot of sense, and it isn't about innovation. Then there's all the drugs that are really incremental in terms of what they're providing to patients' health or to population health, and there we have a lot of incentives already that actually pull those into being, and if anything, perhaps we've overdone it in some areas, like cancer. And then there are true cures. or things that truly transform people's lives, either in terms of their ability to be well and take care of their families, or that are real cures. And there, I think our system still provides under incentives for treatment. And thinking harder about financing incentives, thinking harder about other types of ways that we can incent companies to actually want to create cures, and get the financing to do it all the way through the system needs some more work as well.
Rebecca, I'll get you in, and then I think we'll get some questions from the audience.
Yeah, no, I think that there were a lot of great ideas thrown out. I mean, the only thing I would say is, I think there is an issue around prioritization of what's really high value, what is the value it provides, not only to patients, but to public health. And again, I bring it back to this particular situation. Louisiana is trying to eliminate a disease, right? It's a noble goal, and it's ambitious. And I think when you have a tool, a technology that can do that, and you come together, I think that's a very powerful thing, right? And so there are high value technologies out there, drugs, whatever it may be, and there are also things that may not produce certain types of value. Not everything can be a cure. I also want to slip that word, right?
Absolutely.
It is the ultimate goal of a lot of companies, but we're not there yet. So I would just say that.
Great. All right, we've got a few minutes left for questions from the audience. So we have some microphones coming around. Gentleman here.
Yes, hi. Dr. Gee, congratulations on your
yourself.
successful...
Can you introduce yourself before?
Oh, my name is Stephen Spitz. Congratulations on your successful negotiation on the part of the state of Louisiana with the pharmaceutical company. There was another person from the state of Louisiana named Billy Tozin who put in a little sentence in the Medicare Part D that Medicare, the largest purchaser of prescription drugs in the country, cannot negotiate drug prices with the drug companies. And I'd like the panelists to address that issue.
So Medicare can't negotiate drug prices.
Yeah, I mean, it's difficult. I mean, Billy Tozan, the only American in history to be the whip for both the Democrats and the Republicans, had a major role in creating the pharmaceutical lobby. That regulation makes it very difficult because the bottom line is Medicaid follows Medicare policy. Once Medicare signs a rebate agreement, we must cover it. It doesn't matter what the price is. Now we have tools like pharmaceutical, PBMs, who can then negotiate placement on formularies or tier certain things, but we cannot say no. And in any negotiation, the ability to say no is very important. If you talk to somebody like Peter Sands, who's been very active in Britain, who has NICE, the National Institute for Clinical Effectiveness, he has said to me, Rebecca, it only takes 1 in 30 or 50 times to say no, and you don't say no to everything, but just the ability to say no he thinks has dropped their prices by 25%, let's say. So I do think it's important to be able to say no to low value things, to things that have marginal benefit, things that don't offer better health or cures or don't make meaningful public health impact, and we currently do not have that ability.
So there's actually, I think a couple of years ago, both me and Rena wrote a counterpoint on this for a journal called Journal of Policy Analysis and Management, where I was arguing that we should not allow Medicare to negotiate drug prices, and Rena was arguing for negotiation. So the reason why I don't want Medicare to negotiate drug prices, or why I argued for that case, is because we already do. So it's not that we're not negotiating drug prices. PBMs do negotiate drug prices on behalf of health plans. These are the Part D plans that provide prescription drug insurance. And the second thing is going to Rebecca's point, which is the way to negotiate is to say no. That's what gets you lower prices. So the question is, who has a better ability to say no? Someone who's like, suppose you say no to a drug company that's based in Ohio. What's going to happen? What if the one patient who could benefit from that drug doesn't get the benefit from the drug. So it's not easy to say that the government will negotiate drug prices and the government will do a better job negotiating rather than a PBM. And that's the reason, because the government might have a tough time saying no because, of different political considerations and pressures. You could argue that the government can lower prices by just setting them, but then it comes to this trade-off between innovation and access. And I think there are better ways of kind of preserving that trade-off and still getting access.
All right, I think,
sorry.
sorry.
It's okay.
Final
so as
thought.
you can see, Niraj and I have been arguing forever. No, I think bottom line is that for the drugs for which there is very limited or no competition, and there will be no competition in the future because they're very small market drugs, the government doesn't actually have any ability to say no, and we risk bankrupting ourselves or just stark trade-offs that really do actually impede people's access to important things. And so having a stick, and really an additional stick, we have some sticks already to actually get prices into a reasonable range, particularly not for drugs that are covered under Part D or are oral drugs, but really the drugs that are injectable or infusible into patients. We have no meaningful ability to say no now, and we have no meaningful ability to get those prices down. Those prices are now in the order of $1 million for a launch price of these new drugs, and we're going to keep on going.
All right.
So we need some tools to help.
All right, so I think we'll have to let that be the last word, but there's no doubt that there's a lot more to talk about with drug pricing, and there will be many more discussions in the years to come. I want to hand the floor over now to David Wessel for a conversation with on these and related issues with Wendell Primus of Speaker Pelosi's office. Thank you very much to the panelists.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.